Okay, so when we were talking yesterday, we were going into the breathing system and we were starting to talk about um, the unidirectional valves. And this is what controls the flow through the machine and make sure that they don't get a mix of gas. Because when they inhale, we want them inhaling fresh flow and from the rebreathing bag. But when they exhale, that has to leave to go through the soda lime or out the pop off. And so the unidirectional valves control that flow. Um, and again, I talked yesterday, when they inhale, you will see one open, and when they exhale, the other one opens. And so as long as those are functioning, um, there will be a direction of flow. And usually you don't have to mess with those valves. Um, there's usually a dome somewhere on top of the machine and it's usually clear, where you can see these little plastic discs. And again, when they inhale or exhale, and again, you can use them to count respiration. And a lot of times they get louder the deeper and the faster they're breathing. So sometimes you'll be able to hear a change in that pattern, and it can kind of trigger you that your patient's getting light. Now, the pop-off valve is, and most people call it the pop-off valve, it also goes by the exhaust valve or the APLV valve, which is an adjustable pressure limiting valve. But most of the time, most people call it the pop-off valve. And this is what allows excess gas to leave the system, and it prevents excess pressure of gas within the breathing circuit. Because again, when the animal is hooked up to the breathing system in the machine, you have a constant flow, which again, if the pop-off was closed and it can't leave, then all of your gas is trapped between the patient, the breathing system, and the machine. And so we want to make sure that pressure does not build up. And that is, again, the only time the pop-off is closed is when you're manually ventilating a patient, when you're giving them a manual breath or bagging them. And then when you test the machine in the morning, when you want to test the machine and make sure there's no leaks, you have to close it, pressurize the system, and then open it again. And a common mistake that people make when you guys go in the morning as an anesthetist, one of the first things you do is you go in and you check your machine. And a lot of people close the pop-off, pressurize it, check it for leaks, and then they go to drop their drugs and check their patient, forgetting that they closed the pop-off valve. Now, you just want to make sure as soon as you're done, because you don't want to then go take the patient in there and inadvertently leave the pop-off closed. If you have left the pop-off closed by accident, you'll see your rebreathing bag get very, very big. And I will tell you guys, it happens. It's a mistake. I have left the pop-off closed before. What happens sometimes is you close the pop-off, you give the patient a breath, and then someone says, hey, where's this drug? And you turn to answer a question, and it's easy sometimes to get distracted. But if you look back, your rebreathing bag should never be too full, and I don't like it to be too flat. It's kind of like the porridge in the Three Bears. It's not too hot, it's not too cold, it's just right. You always want some air in that bag, but you can't be flat and it can't be too full. So you just periodically have to look at your bag and make sure. Now, the pop-off valves that we have at school are the button valve. So when you push it and you squeeze the bag and you let it go, it automatically opens up. But a lot of clinics, that's kind of a newer adaptation. A lot of clinics may have the traditional, you turn the pop-off closed, righty-tighty, lefty-loosey, and then you have to untwist it manually. And those are the ones where it's common to accidentally leave it closed. So you just want to be really cautious and be able to tell me when you close it. Now, I will tell you, and I'll tell you this closer to surgery. The machine in the surgery suite at school actually has a button and a turn. And to bag the patient in the OR, you have to twist that closed and push the button. It's kind of strange. The ones in the prep room, both of those machines just have the button that you can push and squeeze the bag. So this is what it kind of looks like. I mean, and some of them are just like a black dial. This one's silver with a button. And that's why I tell you time and time again, whenever you get to your clinic or job shadow or wherever you're working, a lot of clinics have multiple different machines. Just make sure that you understand how that pop-off works before you have a patient on the machine, because again, you don't want to use it for the first time. So again, if you go to give the patient a breath, you would twist this closed. On this one, you would push the button, and I'll explain this week 8, but when you push that down, that's when you squeeze the bag. If you didn't close the pop-off valve and you go to squeeze the bag for your patient, it's all going to go out the scavenge system, because it's going to go the path of least resistance, and it's easier for it to escape out the pop-off than go to the patient. So if you go to squeeze your bag and it just feels really easy and you don't feel any pressure, then you probably left the pop-off open and you squeeze the bag. And when you squeeze the bag, you don't squeeze it and hold it. Imagine that you were taking a breath. Usually we say, you take a breath while you bag the patient, and you just, because a lot of students sometimes the first times kind of squeeze and hold, and that's the equivalent of you going and holding your breath, which is not how you breathe. You want it to be a very natural, that IE ratio. Inhalation is shorter than exhalation. So when you squeeze, I just tell the students, breathe with you bagging, and you just do it the same. And then you let the pop-off go. So we'll practice that when I can get you in front of a machine and you can actually, and I think Mrs. Long in surgery, you guys will work with the machines, and I think she probably models that for you as well. So you might get some practice. Now the reservoir bag, which most people call it the rebreathing bag, it should be a flexible rubber bag. Sometimes they're made of different material. The nice thing about the bag, it's a good way to count their respiration. Again, when you have an animal in surgery, usually they've got a big drape on them, and sometimes they're big enough where you can see the drape move and you can count respirations based on the, but a lot of times I watch my bag and I look at my watch and then I watch them breathe. So first of all, it's an indicator of respiratory rate. It's also an indicator of how deep are they breathing, because again, sometimes you'll see when they're breathing deep, they really expand and collapse the bag. And sometimes the bag is barely moving when they're breathing shallow. So you can kind of get an indication like, wow, my patient was breathing really deep before and now they're breathing really shallow, which could be an indication they're too deep. So you can use that as an indicator, because again, sometimes the smaller patients are hard to get an idea of how deep they're breathing under all those surgery drapes. So you can use this. And the other thing I told you, it confirms that your endotracheal tube is in the right place. Because again, if you saw the chest of your patient moving and your bag is not moving, then that means your tube is in the esophagus, which happens. So that means you're gonna have to take out your tube and put it in again. Because if they're breathing, the bag should be moving if everything is hooked up properly. And if you checked your machine before the procedure like you're supposed to, you would confirm that, okay, the machine's set up properly. It's got to be a patient problem, an endotracheal tube problem. It allows us to ventilate the patient as well. So when, and I told you guys, every patient under anesthesia should get a manual breath every 3 to 5 minutes, regardless if they're breathing normally, just to prevent atelectasis. And, there's some degree of respiratory depression. Now, if an animal has a very low respiratory rate, like if they're breathing 6 to 8 times a minute, you may need to breathe for them once a minute, so, and again, you guys, in surgery, you're going to have the machine hooked up to a capnograph. What does a capnograph measure? What do I look at my capnograph for?
It measures the amount of CO2 in your end tidal breath.
Yep. So again, 35 to 45 is normal. And if your patient is above 45, like they're 50, 55, 60, that means they're retaining CO2, which is usually because they're respiratory depressed. So those patients probably, and the only way to get rid of CO2 is to ventilate them. And if they're not going to ventilate themselves, you're going to have to do it. So again, you know, I love CO2. So my best bet is if you have a capnograph, to use your CO2. Again, if my patient's staying between 35 and 45, once every 3 to 5 minutes is going to be adequate, probably. But if they're creeping, and I've had patients 70, 80, I had a patient once that was 90 in the CO2s, then you're going to have to ventilate a lot more often. So the bag does this, and there's different sizes of bags. If we look at, these are called Roush bags. You don't need to know that, but these are probably my favorite bags. The ones we have at school are like green. They're like a thinner plastic, so they tend to break. And this is where it hooks up on the machine. So somewhere near your exhalation valve and your pressure manometer, you'll usually see a little pipe, and you'll see where you hook the bag up to the machine. Now, I'm not going over the calculations. You'll have your surgery packet, but normally I do 30 mils per pound is the shortcut to calculate the bag. And for example, if you calculate for your patient 1,500 mils, 1,500 mils is 1.5 liters. We don't have a 1.5 liter bag. You always want to round up and go to a 2-liter bag. So because you want to give your patient enough space, because you'll have, if you're lucky, a small animal clinic usually has liters 1, 2, 3, 4, 5. So you'll have, you know, one of each. And at school, we have all of them. Some clinics, you might have 2 bags. You always want to choose the bigger bag to make sure, because if you choose too small of a bag, when your animal exhales and the bag is too small, it could put excess pressure on the lungs and not hold adequate volume for inhalation. So always round up is your rule. And then in large animal, it's kind of hard to see. They use a 15-liter and a 30-liter bag. So the rule is, very rarely will you calculate, oh, my patient needs 2,000 mils, I need a 2-liter bag. It's going to sometimes fall between a range. The rule is just to round up, to choose the bigger bag size. The consequence, say for example, you had a 20, 30 pound dog, and all you had was a 5-liter bag, which is big. Now, when an animal inhales, they have to be able to pull air to themselves to inhale, and they have to pull that bag. Sometimes with too big of a bag, it may create more work for them. So you just have to monitor their respiration, monitor their effort, monitor their CO2, and maybe have to help them. But most clinics will have, you know, a fair amount of sizes of bags, but they are even size. There is a 1/2-liter bag, a 500 mil bag, and that comes with our non-rebreathing system. So the ones we use for 15 pounds and under, the bag that comes with that is a 1/2-liter bag. And so, you know, and if you can use a bag that size, you can put it on a rebreathing system, but typically 15 pounds and under, they're usually, or if they're close to 15, 17 pounds, they're probably going to be around a 1-liter bag. So, now I told you, and you have to know, why do you bag? And hopefully you've understood this by now, is first of all, to minimize atelectasis. And that's, atelectasis is areas of collapsed lung, not like the whole lungs collapse, but when you have alveoli that aren't being inflated, they're considered atelectic. And a patient that's respiratory depressed is going to have a higher degree of atelectasis than an awake patient. So number one, it prevents atelectasis. And it also kind of flushes the lungs. You flush out some CO2 and you flush in some fresh gas. So you're kind of maintaining that gas exchange when you ventilate them, because obviously when you bag your patient, you are more efficient than when they're breathing. So it normalizes that, and it helps normalize the respiratory rate. So again, if you have a patient breathing 6 times a minute, which is kind of like my cutoff for most patients, I like them 8 and higher. Cats are usually higher, dogs, but when they get to about 6 breaths a minute, that's a pretty low respiratory rate. It's still acceptable, but it's on my low end. I'm going to be breathing for them more often, and then that's going to supplement their respiratory rate. So, and let me go back to a picture here for a second. Okay. And I'm going to talk about this part, but this gauge up here that I'm pointing to, this is called the pressure manometer. If you remember, when your pop-off is open and they're breathing on their own, they don't typically generate pressure. This is measured in centimeters of water, cm. I'm going to type it here in the chat real quick. Okay, so when you go to bag a patient, you're going to push on this button. Sorry, where's my arrow? Okay, you're going to push on B. You're going to push that button down. This bag is going to get full, and then you're going to squeeze the bag while the pop-off is closed, and you want to watch this gauge, and you don't want to go past 20 centimeters of water, which I believe is right here. That's normal bagging pressure. When you go over 20 centimeters of water, if you go up to 30 or 40 centimeters of water, you're just putting excess pressure in the lungs, and you're putting excess pressure inside the thorax. It can compress blood flow. It can damage alveoli. So normal bagging pressure is 20 centimeters of water. You don't want to go above that. And when you guys test your machine for leaks, you're going to test to 20 centimeters of water, because you have to make sure your machine can hold 20 centimeters of pressure, because that's what you're going to bag your patient at. So just to remember, when I want you to know that number, is that's normal bagging pressure is 20 centimeters of water, and be able to tell me why we bag the patient. So even though this test is equipment, it's important to know the reason we're bagging. And your carbon dioxide absorbent, the main ingredient in these little white granules is the calcium hydroxide. There's sometimes different chemicals, but that's the primary chemical. And what happens is when the animal exhales, the exhale gases go through this canister, and those granules absorb the carbon dioxide. Now, when the calcium hydroxide interacts with CO2, it actually creates heat and water. So sometimes you'll look at that canister and you'll see condensation, and you might actually see droplets because of that chemical reaction. So that's actually a positive sign, because it's showing you that there is a chemical reaction. It is occurring. And it can become more acidic the longer you use it. So you just have to be careful. The granules have to be replaced. Now, there's some rules down here, but let me tell you what most people do. So here's what a canister looks like. I mean, some of them are a little bit different. I don't know if you can see at the top, it looks a little bluish purple. There is a chemical reaction and it changes color, and usually it turns purple. If you guys were doing anesthesia and this was half purple or 3/4 purple, I would go ahead and change it after that procedure. It's very difficult to, I wouldn't change it in the middle of a procedure. If it's not working, your CO2 is going to be high. I would just continue to bag my patient, And when the patient's off the machine, I would go back and change the soda lime. The problem is the purple does not stay purple. It'll go back to white. So if it changed purple and you left it and you go back there a couple hours later or that afternoon, it's probably going to go all back to white. So that's why if you're the person that recognizes it's purple, you're going to want to change it. And these canisters, if you see there's some wing nuts up here, all you do is you untwist those and the canister will lower, you pull it out and you just dump it in the trash. Doesn't have to be in like hazardous waste. You just dump it in the trash and then usually there's some bucket and you pour in new granules. Now, there's a piece of tape here and it has a date. So when you change it, you want to put the date and your initials. Normally in surgery, we change it once a month. So most clinics, you usually change the soda lime once a month. So you just check the date, and if it's a month, you change it. But if you had like two big dogs, like if you had a German Shepherd and a Great Dane on the machine back to back, you may deplete the granules sooner. I can't say there's a formula where you could calculate, but roughly it's kind of it deals with the oxygen flow, how long the patient is on the machine, how fast you're going to deplete it. And again, if you do like 2 or 3 big dogs, you might deplete it even if it was changed last week. So you want to look for the color change, or at minimum change it once a month. Now, if you have a patient on a machine and you're noticing super high CO2s, sometimes people will change that just to say like, well, maybe, there's lots of reasons for elevated CO2. So you can't always blame it on the soda lime, but that could be the issue, was that if the soda sorb or the soda lime is expired and it's not removing CO2, then CO2 is probably making it back in the rebreathing bag, and then they're rebreathing that. So sometimes that can be a reason for an elevation in CO2. So there's some notes under here. The big things to remember is it removes CO2, change it once a month, unless you change it purple or you see it's purple. The other thing you'll notice about soda lime, when you have fresh soda lime, when you open a canister, the granules actually feel moist and they crumble. Like if you rubbed them in your fingers, it will actually get crumbly. When soda lime is exhausted, when it's expired, the granules are very hard and dry. They're not crumbly anymore and they're not moist. So sometimes you can open the canister and feel them. I had a practical final. When I was at Purdue, we had an anesthesia practical, and my instructor had 2 bowls or 2 little cups of soda lime, and we had to feel it and tell him which one was fresh and which one was expired. And obviously, if it's moist and crumbly, that's fresh and brand new. And if it's kind of hard and dry and kind of brittle, then it's expired soda lime. So that's how you can also tell the difference. So I kind of just talked about the pressure manometer, but it tells you the pressure within the circuit. And again, the circuit is hooked up to the machine. So it's really the pressure between the patient and the circuit and the machine. And again, it is measured, our machines are centimeters of water. So it's not millimeters of mercury, it's CmH2O. And when you bag, that's the only time you should generate pressure on that gauge. When the pop-off is open and the patient is breathing on their own, they don't generate pressure. First of all, your pop-off's open, so there shouldn't be pressure within the system. The other thing I should mention is you don't want it to go negative. If your pressure goes negative below the 0, if your scavenge system is turned up too high, it can be sucking from the system. So ideally, it should be at 0. When they're breathing, the only time it pressurizes above 0 is when you're bagging, and it should never be negative, where something could be pulling from the system. And it's our job to watch it. Now, this is kind of what I was showing you. This is what it'll look like or what I was kind of describing. When you go to give a patient a breath, you're going to hold the pop off and squeeze the bag at the same time. You have to make sure you have enough gas in your bag to squeeze to your patient. But look at this gauge. You can see that the gauge is now showing pressure because the top is 0. So they are giving positive pressure to the patient. When they let go of this, all of that's going to go out the scavenge system, out the pop off, out your scavenge tube. So the only time this is closed is when you're squeezing and giving a breath. And 20 centimeters is your, the pressure that we want to deliver. This wasn't on, I don't believe this part was on your list of parts. I'll just mention some machines have an air intake valve, and sometimes it's called a negative pressure relief valve. So for example, if the machine was under negative pressure, remember I said if your scavenge system was sucking from your machine and it was going negative, I will show you. There's some machines on the top of, this is one of the, see where it says inhalation valve down here? And then this is the dome, and there's a little white disc there. And there's a nice close-up of your pressure manometer right there. If your machine was going negative, these little holes would be able to suck in room air so the patient could get air. And when you know this is happening is if your rebreathing bag, if this bag was flat, like collapsed, something has either formed a leak or your scavenge system is sucking from your patient. Now, at school, there is a valve in the ceiling that you can adjust how much suction is being sucked from your bag. That should never be adjusted. That's usually set. There's usually, it's usually tested and set, and nobody has to adjust that. But if somebody by accident turned up the scavenge system, turned up the suction, and then it started making your bag go flat, that would be a problem. So you always want to make sure that you have pressure in that bag. You always should have some, oxygen and anesthetic in that bag. And that's the job of the air intake valve. So negative pressure can be indicated by a flat bag, or you have a leak somewhere. I had a student with a flat bag and the breathing system was laying on the floor. The breathing system became disconnected and she was writing numbers down and didn't realize that it somehow became disconnected. And all of a sudden I see a flat bag from the back of the room and I was like, oh my gosh, the bag is flat. And I go over and I'm like, oh, your breathing system's laying on the floor. Hooked it back up. So it can also happen if something becomes disconnected. If the oxygen got turned off, the bag will go flat. But also if scavenge is taking too much from the machine. And eventually your patient would become hypoxemic. So if your patient started having a hard time breathing, like they were abdominal breathing, if they turned blue, if their SpO2 was falling, those are all signs that the patient isn't getting oxygen and we've got to figure out the problem. Okay, so let me go back to the breathing systems, which I've kind of talked about. They are corrugated tubing, meaning they have ridges. Sorry, and the reason they have the ridges is to mix the gas. So they usually there's always an inspiratory tube and an expiratory tube. But again, the tubing does not direct the flow. The way you hook up the tubing to the unidirectional valves, that's what controls the flow through the system. And you don't have to worry about the diameter. Don't worry about those numbers. You're going to just hook them up by weight and by system, not by diameter. But they connect the Y piece, where the Y piece comes together, that's what connects to the mask or the ET tube. So a couple different systems we have here. Let me just explain the difference. Letter C at the top is what we have at school, and that is called a coaxial rebreathing system. Coaxial means a tube within a tube. And if you look, there's blue. Inside, there's a solid blue tube. That is the inhalation tubing. And then the outer tube is clear, and that is the exhalation tube. So the inhalation tube goes inside the exhalation tubing. Now, what's very important on these machines is you see, these are the two ends that I'm pointing at that hook up to the unidirectional valves. You have to hook up the blue side to the inhalation valve because that's the inhalation tubing. If you flip these backwards, your patient cannot breathe. So it is very important to make sure you hook up the right tubing to the right part of the machine. So the blue side, if you see that blue tube in there, that is the inhalation tube. Now, some of the tubing at school actually has this marked inhalation. And if you're in a practice, get a Sharpie and write INH for like inhalation, if it helps you remember which side. But if you know the blue tube is the inhalation tube, has to hook up to the inhalation valve. And then this other tube, so what happens is when they inhale, okay, they inhale here. This is the side that hooks up to the patient. They inhale, and when they exhale on the exhaled around the blue tube. The advantage to this tubing is the exhaled gases are warm. They actually warm the inhaled gases because they're exhaling warm gas around that blue tube. So some people like this because it keeps the patient warmer. There's one thing I don't like about coaxial tubing. If for some reason inside that blue tube got cracked or broken, they could inhale because the tube around it has CO2 in it. So if there was a crack inside, they could inhale CO2. So that's kind of the difference in this tubing. I'm used to these Y pieces. This is called a Y piece. Now, when you hook up these right here, you could hook up to either side, it doesn't matter, because one is going to go to inhalation and one is going to go to exhalation, then they come together at the patient end. And some clinics have this black tubing. They're all corrugated, but this black tubing is a rebreathing system, a rebreathing Y piece. And the only problem is you can't see through here. If your patient was breathing in one of these and they started kind of coughing up like mucus or blood, you can see. You can also see humidification. So you can see that they're breathing. In this tubing, you can't see what it looks like. So I'm not a huge fan of the black tubing. That's older. The large animal tubing is usually black tubing. It's a little bit stronger rubber, so it's up to wear and tear. And then let me mention a size here. So letter A and letter C up here are what are called adult rebreathing systems. These are used for patients 30 pounds and up. This one in the middle is called a pediatric rebreathing system, and that's for patients 15 to 30 pounds. So let me type, because I want you to know those cutoffs. 15 to 30 is pediatric. And then 300 and up is large. So if you remember, the cutoff for large animal is 300 pounds. So 30 to 300 pounds is going to take these standard, these are called adult rebreathing systems, and then there is pediatric tubing. Now let me give you some advice. Every once in a while, you're going to get a dachshund that looks like a coffee table. I joke. And that dachshund might be 18 pounds. And so technically they're the pediatric rebreathing because they're above 15. But if I look at that dog's probably supposed to be 12 or 13 pounds. So sometimes I will have a dog that's kind of on that border of the weight, And I have to look at the individual patient, because that dachshund that's 18 pounds has the heart and lungs of a 12-pound dachshund trapped in an 18-pound body, if that makes sense. So when I get into animals that are obese and they are maybe on the border of one system or the other, I may choose the smaller system. But in general, you just go by weight ranges. 0 to 15, oh, then let me put, I haven't talked about this, but 0 to 15, if I can type, wow. So 0 to 15 are non-rebreathing systems, 15 to 30 are pediatric rebreathing systems, and 30 and up are going to be adult rebreathing systems. And that's your cutoff. And then again, if you have a patient that's kind of on the border in between two, and you have to kind of look at their weight, and it might be okay to go with the smaller system, because we want to make it easier for them to breathe. So these are the types of tubing that you'll see in practice. And then I'll get into a non-rebreathing system. And these are also called a semi-open or semi-closed system. Don't worry about use the weight ranges I told you, 15 pounds and under. This means exactly what it says. They are not rebreathing their exhaled gases. The fresh gas is coming in a tube at a higher flow. And so when an animal exhales CO2, the way, and this is important, the way CO2 leaves a non-rebreathing system is when they exhale, the fresh gas is pushing out the exhaled gases. So you're relying on the flow rate, the oxygen flow, to flush CO2 out of the system. Because when you hook up a non-rebreathing system, you do not have soda lime, you don't have your pop-off valve, you don't have your pressure manometer, so you don't have CO2 to remove CO2 when they exhale. So there is little connection. Let me, hang on, where is the, okay, let me just show you. So like this tubing, this is a special connector. This isn't what it looks like at school. But basically the non-rebreathing system that you guys use will have a clear tubing that's going to bring oxygen and anesthetic. And when the animal exhales, it's going to go around this clear tubing, or it's going to go out the clear toes. And then there's a blue hose, and that's how exhaled gases leave. Let me get back to, don't get dizzy. And when we get to play with the machine, I'll show you how to hook up both systems. And I did post a video on your Moodle page. There's one going through a machine, and there's one video about breathing systems that'll probably explain this a little more. But if I look at this diagram, okay, the top is a non-rebreathing system. When you hook up the inhalation tubing, it's going to hook up at the outlet of the vaporizer. At school, there's a little adapter, and you're just going to disconnect it, and you're going to put in the adapter of the non-rebreathing system. When the animal inhales, that inhalation tube goes to the patient. This is the ET tube. And when they exhale, it's going to go through this tubing, through the bag, directly to the scavenge. If you notice, you don't have all these, you don't have all these parts. Now, at school, we bought these really cool things, and not all practices will have them. It's weird. There's a little adapter that's a little mini pressure manometer that hooks up at the rebreathing bag. It's a little piece that can come disconnected. So when you squeeze the bag, it actually squeezes to the patient, and it actually measures your pressure. At a lot of clinics on a non-rebreathing system, when you close, there's an open-close valve. It's not really a pop-off valve because you don't have the pop-off valve right here. So directly on the non-rebreathing system, there's a little valve that you close. And when you squeeze the bag, you have to kind of do it by feel. You don't have, most clinics aren't going to have that little pressure manometer. But at school, we bought these little, like I said, it's an adapter that goes between the bag and the tubing. So when you guys close it, you can actually watch and see how much you're breathing for them. So the key to a non-rebreathing system is to know basically you are bypassing your soda line, your pressure manometer, your unidirectional valves. So if I ask you what controls the flow through a non-rebreathing system, it is your oxygen flow rate. Your oxygen flow rate in a non-rebreathing system is going to be higher than in a rebreathing system. And what's unique is you're using, most of the time you're using these non-rebreathing systems for cats. And you may have a higher flow rate for an 8-pound cat than an 80-pound dog, okay? And the reason for that is because you need a higher flow. So when the cat exhales, the fresh flow is pushing out the exhaled gases. Now that bag, when an animal inhales and exhales, you will see the non-rebreathing bag move. But when they inhale, the majority of what they're getting is going to be that fresh gas coming from the outlet of the vaporizer. So little exhaled gas is returned. I mean, a small amount, but very little is going to go. Most of what the patient breathes is going to be fresh, is that high fresh flow. The exhaled gases are going to leave the scavenge. So that's how the CO2, we get rid of it. Now, if I have a cat on a non-rebreathing system and I'm getting high CO2 levels, a lot of times I'll turn up my oxygen flow and I'll try to get that to push out more CO2, because maybe they are at the connector when they're inhaling and exhaling, maybe they're getting mixing of gas. Because again, I don't have soda lime. So I'm relying on this fresh gas to come in and push. As they exhale, it's supposed to push that gas out of the system. The fresh gas that the patient gets is coming directly from the outlet of the vaporizer. So a common thing, you know, I'll send students in to hook up a machine and they're kind of standing with this tubing and they're like, okay, where am I going to put this tubing? I'm like, well, this tubing needs oxygen and anesthetic in it. Where is the place where the first place you have oxygen and anesthetic? And you look at the outlet of the vaporizer, and at the tubing, like I said, there's a little connector and you disconnect it, and the end of that tubing fits right into that adapter. So right from the vaporizer, it goes directly to the patient. Now in a rebreathing system, that tube from the outlet of the vaporizer connects at the inhalation valve, and then it goes into the breathing system. So that's the difference. And again, I would watch the videos that I posted on Moodle so that you're familiar with tracing the flow and setting this up. So I will stop right here. Do you have any questions based on that? So some of the things to know from this lecture is, first of all, what are the cutoffs in the breathing system? And what is the difference of the, patient size, and also how is the flow controlled in both systems? Again, the unidirectional valves control the flow in a rebreathing system. The flow rate, the oxygen flow rate, controls the flow in a non-rebreathing system. And then remember, your pressure manometer is your centimeters of water, and that's 20 centimeters is a normal breath.